All right, good morning, everybody. It is October 9th at 9 a.m. This is the SISU Integrated Health LLC docket number 24-32709-CON. The SISU Integrated Health LLC, the applicants in this matter seek a certificate of need for the establishment of a healthcare facility pursuant to Connecticut General Statute Section 19A-638, small a, 10. Specifically, SISU seeks authorization to establish a psychiatric outpatient clinic for adults and a freestanding facility for the care or treatment of substance abuse or dependence. Throughout this proceeding, I'll be interchangeably referring to SISU Integrated Health LLC as SISU for brevity purposes. Today is October 9th, 2024. My name is Alicia Novi. Dr. Deidre S. Gifford, the Commissioner of the Office of Health Strategy, designated me to serve as the hearing officer for this matter, to hear on all motions and recommend findings of facts and conclusions of law upon completion of the hearing. Public Act number 21-2, as amended by Public Act 22-3, authorizes an agency to hold public hearings by means of electronic equipment. In accordance with this legislation, any person who participates orally in an electronic meeting shall make a good faith effort to state his, her, or their name and title at the onset of each occasion that the person participates orally during an uninterrupted dialogue or series of questions and answers. We ask that all members of the public mute their device that they are using to access the hearing and silence any additional devices that are around them. This public hearing is held pursuant to Connecticut General Statute Section 19A-639A, F, 2, which provides that HSP may hold a public hearing with respect to any certificate of need application submitted under Oh, actually, hold on one second. Let me just make sure I do have the right. For some reason I do apologize. I think when I did this that I did not. Attorney Lazarus, is this an F2 or do I have that wrong? All right, Mr. Lazarus. Do apologize.
I'll just pause the record.
Yes, please. We could just pause for a quick second. I just want to check something. Attorney Lazarus, do you have the or no, Attorney?
Back on the record.
I do apologize. I just wanted to make sure I had the right hearing and I was giving the right notices for this. All right. Mr. Dixon, a second to get resituated. All right. So this is it's being held pursuant to Connecticut General Statutes 19A-639A, small f, 2, which provides that HSP may hold a public hearing with respect to any certificate of need application submitted under Chapter 638Z. Although this is a discretionary hearing, the manner in which OHS conducts these proceedings will be guided by Chapter 54 of the Uniform Administrative Procedures Act and the regulations of Connecticut state agencies codified in sections 19A-9 through 24. The Office of Health Strategy is here to assist me in gathering facts related to this application and will be asking the applicant witnesses questions if warranted. I'm going to ask each staff person assisting with questions today to identify themselves with their name, the spelling of their last name, and their OHS title. We'll begin with Mr. Lazarus.
Good morning, Stephen Lazarus, Lazarus, and I'm the Certificate of Need Program Supervisor.
Thank you. Ms. McLaughlin.
Good morning. My name is, let me get my video off. Good morning. My name is Yadira McLaughlin, and I am analyst at Office of Health Strategy for the CON
Thank you.
team.
All right, Miss Marino?
Good morning. My name's Olivia Mariano. I'm a planning analyst with the Office of Health Strategy, and my last name is spelled Mariano. Thanks.
Do apologize for the spelling of your last name. All
No
right.
worries.
Also present is Faye Fentis, and her last name is spelled Fentis, a staff member from our agency who is assisting with hearing logistics and will also gather the names for public comment. If you would like to register to make a public comment, that is open at this time, and you may do so in the chat function. The certificate of need process is a regulatory process, and as such, the highest level of respect will be accorded to the applicant, members of the public, and our staff. Our priority is the integrity and transparency of this process. Accordingly, decorum must be maintained by all present during these proceedings. This hearing is being transcribed and recorded, and the video will be made available on the OHS website and its YouTube account. All documents related to this hearing that have been or will be submitted to the Office of Health Strategy are available for review on our Certificate of Need portal, which is accessible through the Office of Health Strategy's CON webpage. In making my decision, I will consider and make written findings in accordance with Section 19A-639 of the Connecticut General Statutes. Lastly, as Zoom has notified you either upon entering this hearing or at the start of this hearing, I wish to point out that by appearing on camera in this virtual hearing, you are consenting to being filmed. If you wish to revoke your consent, please do so at this time. The CON portal contains the pre-hearing table of record in this case. At the time of at 4 p.m. on Tuesday, exhibits were identified in the table from A to R, though there are some others that I will get to. The applicant is hereby noticed that I am taking administrative notice of the following documents: the statewide healthcare facilities and services plan, both the current 2024 and the previous editions, the facilities and services inventory, and the OHS acute care hospital discharge database, and all payer claims data. Let me say this again: all payer claims database claims data. I may take administrative notice of the hospital reporting systems HRS and financial and utilization data, and also prior OHS decisions, agreed settlements, and determinations that may be relevant to this matter. Attorney counsel for the applicant, can you please identify yourself for the record at this time?
Cowherd of Pullman and Conley, STEPHENCOWHERD, representing the applicant, SISU Integrated Health, LLC.
Okay, Attorney Cowherd, we only kicked in at Cowherd, so I missed everything that came before that. So if you would like to just start at the beginning or at least get to before Cowherd.
Certainly, hearing officer Nobi. Again, it's Stephen Cowherd of Pullman and Conley. The spelling of my name is STEPHENCOWHERD, and I am here representing the applicant, SISU Integrated Health, LLC.
Thank you very much, Attorney Cowherd. All right, so as I said, as of last night at 4 p.m., when I was writing these, making sure these instructions were finalized at 4 p.m., in the portal at that time were exhibits A through R, which was up through applicant's request to submit record, supplement the record.
Yes.
I do notice that we have 2 new exhibits that came in this morning, which we can deal with. Are there any objections to A through R?
Yes, there is. We'd like to address Exhibit D and
I'm sorry,
oppose
was
that.
Yeah, just for my clarification, was that E as in elephant or D as in dog?
That is D as in dog, hearing officer.
Okay.
Okay. That is the initial letter submitted by Connecticut Center for Recovery. We have evidence, hearing officer, that we like to submit either after this hearing or during the hearing. with respect to the origination of that unsigned letter from Mr. Lavalsi. It was instigated by another party for what we believe was an improper purpose, and ghostwritten by yet another party who did not identify themselves. And the metadata shows that. On top of that, it was provided to others for a reason that is not substantive in terms of need. It was and appears to be out of personal animosity. In some, we believe it was written for an inappropriate purpose to influence this agency. We'd like it stricken. We understand that there's been a supplemental letter uploaded this morning. We do not object to that one, but we do feel that the supplemental letter is tainted by the origins of this letter, and we'd like it stricken from the record, and we'd also like the opportunity to present the evidence that we have as to the motivation of that letter to the agency in either a late file or however the hearing officer deems appropriate. We will let the agency obviously deem and decide the appropriateness of what we're opposing.
Okay, I have read both of those. I do want to give you proper time. I do want to give you proper time to respond to both. So I feel that it would be appropriate for you to do a late file with your response to those, considering that that Exhibit S, which was a public comment, did not go up until 6:54 today. I do feel that it is appropriate. We'll address it for time frame of getting that back to us later when we address all the late files. But I do feel that late file 1 will be the response to both public comments.
Yes.
Okay.
And now I understand, hearing officer, and respect that the letters uploaded this morning have not been formally deemed exhibits in this proceeding, but to the extent that the greater, Boston Addiction Center submitted a letter regarding one of the principals for the applicant, who I'll introduce in a moment. We'd also like the opportunity not only to submit a late file with respect to that letter and its origins, but also have Mr. Silva address that in his remarks to the agency this morning.
Yes, Attorney Cowherd, I'm going to allow him to do both. So why don't we have late file A will be the applicant's response to both exhibits D and S. You may address them at the same time, you may address them in different documents, and then, or if you'd like to go separately and just attach them as one filing, that is also okay. But we will go ahead and I will allow them in because they are public comments. I will give them the weight I deem appropriate. However, I also am giving you a chance to respond to both of those.
I think that's appropriate, and for administrative convenience, I will combine it all in one motion to strike.
All right.
Okay.
We will make that late file A. So am I correct when I heard you say that you have no objection to exhibit S coming in?
Can you repeat exactly?
That was the
Exhibit
public
F is-
comment that was submitted this morning that you're going to respond to.
No.
Okay. And then exhibit T, which was a letter of support that came in at 9:05 this morning. I have not viewed that yet. We are in the hearing, so I haven't seen anything that came in from about 10 minutes before the hearing onwards. But do you have any objection to this letter of support coming in as an exhibit?
Or we uploaded to the appropriate website the letters of support from New Vance Health, from High Focus Recovery, and others. And we have no objections to those letters of support that are coming in.
Okay, so I will mark everything through exhibit T as a full exhibit. All right, Attorney Cowherd, do you have any additional exhibits you wish to enter at this time?
No, and at the appropriate time, hearing officer, I'd like to address the motion to supplement the record that was submitted. We appreciate and we think appropriate to, even though this application was filed before October 1, 2024, to let in the more recent statewide healthcare facilities and services plan. We appreciate that. Given that the two hospitals did their 2022 Connecticut and community health need assessments for their Connecticut service areas, which are a prime focus of this application, and the implementation plans, we respectfully ask that the Norwalk Hospital and Stamford Hospital CHNAs and those implementation plans for 2022 be part of this record as they are submitted per statute and in the files of OHS currently.
I'm going to go ahead and grant that order.
Thank you. Thank you.
We did have the statewide facilities plan coming in previously. That was included in my instructions, but yeah, we will let in the community health needs assessment for both Norwalk and Stamford as well.
With that, hearing officer, I have no preliminary issues with respect to the record. If you would like me to introduce the principals of the applicants.
I'm going to ask you to just pause for a second. I'm going to go through I still have a little bit more in my introduction that I have to go through. I'm going to just now go back to some instructions for everybody. We're going to proceed in the order established for the agenda for today's hearing. I would like to advise the applicants that we may ask questions related to your application that will feel like that you have already addressed. We will do this for the purpose of ensuring that the public has knowledge of your proposal and for the purposes of clarification. I want to reassure you that we have reviewed your application, your completeness responses, and pre-filed testimony, and I will do so many times before making a decision. As this hearing is being held virtually, we ask that all participants, to the extent possible, should enable the use of video cameras when testifying or commenting during proceedings. I'm going to ask also that if you have a last name that may be difficult to spell, that you spell that for our stenographer at the beginning of your testimony. Applicants shall mute their devices and shall disable cameras when we go off record or take a break. Please be advised that we will try to shut off the recording during breaks. However, it may continue. If the recording is on, any audio or video not disabled will be accessible to all participants to this hearing. Public comment taken during the hearing will likely go in order established by OHS during the registration process. However, I may allow public officials to testify out of order. I or OHS staff will call each individual by name when it is his, her, or their turn to speak. Registration for public comment is open and is scheduled to start after the technical portion. Applicants' witnesses must be available after public comment, as OHS may have follow-up questions based on public comment. All right, are there any additional housekeeping matters or procedural questions we need to address before we start?
Not from the applicant.
All right. So at this point, I'm going to ask Attorney Cowherd, do you wish to make an opening statement?
I will waive the opening statement. We'll get right to the testimony in the interest of time, but I will reserve closing remarks.
Of course. And we will have those after public comments. So, all right. So Attorney Cowherd, would you please identify all individuals by name and title who are going to be testifying on behalf of the application? And if they're in the room with you, if you could just state which direction, left or right, they are of you in the room so that we can put that on the record as well.
Yes, to my left is Reggie Silva, the Executive Director of SISU Integrated Health, LLC, REGGIESILVA.
And you want to, we'll do the
Okay,
swearing in after.
Yeah. To my right is Kirsten Clark, who is the clinical director for SISU, the applicant, and it is KIRSTENCLARKE.
All right. Thank you very much. All right, Mr. Clark and Miss Clark and Mr. Silva, if you could please both raise your right hands. I'm going to go ahead and swear you both in at the same time.
Hearing officer?
Yes.
Before you swear in, also on camera is Brian Krulik, BRIANKRULICK, who has served as outside counsel and is also an investor with respect to SISU, who has advised them from the start. As you know, Mr. Silva met with OHS in the process to speak about the application before it even came in. And Mr. Krulik's been involved in that, so he's also on camera for that purpose.
Okay. I apologize for, all right. I'm going to do the two that are in the room first, and then I will go to Mr. Krulik to swear him in. That way, in case he answers questions later, he's already sworn in. All right, Ms. Clark and Mr. Silver, if you could please raise your right hands. Do you solemnly swear or solemnly and sincerely affirm, as the case may be, that the testimony you are about to provide shall be the truth or the whole truth and nothing but the truth, so help you God, or upon penalty of perjury? All right. Actually, I'm going to ask you. I forgot to do this. Mr. Silva.
Yes.
Miss Clark.
Yes.
All right, great. That way we can put the yes with your name. All right. Mr. Krulik, if I could please have you raise your right hand. Do you solemnly swear and solemnly and sincerely affirm, as the case may be, the testimony and evidence you will provide will be the truth, the whole truth, and nothing but the truth, so help you God, or upon penalty of perjury?
I do.
All right. Thank you. Go ahead and put your hand down now. All right. I would just like to remind everybody that when giving testimony, please make sure to state your full name and adopt any written testimony that you have submitted on the record prior to testifying. The applicants may now proceed with testimony. I ask that, and just before they do that, I ask that any witnesses define acronyms that you are using for the benefit of the public and the clarity of the record. Okay. All right. With that, Attorney Cowherd.
Hearing officer, thank you. I apologize in advance if the agency is hearing background noise. Seems to have dulled here from our office, but can't control that this morning. For just the convenience of the agency, is it appropriate for Mr. Silva to address from where he's sitting? Can you see him? Or would you like us to shift to the center of the frame?
Oh,
Or
no,
do
I can see both of them at the same time. So they may remain where they are and testify from where they're currently located.
Okay, if you can just say you adopt your pre-filed testimony. Mr. Silva, go right ahead.
So I adopt my
Pre-filed.
pre-filed testimony.
And if you could just state your name and title for the record, sir.
Sure. My name is Reginald Silva. I'm the Executive Director of System Integrated Health, also the Managing Member, and I adopt my pre-trial testimony.
Attorney Cowherd, do you have any questions, or would you like
No, what we'd appreciate is the opportunity for Mr. Silva, and for that matter, Ms. Clark, to address the hearing issues and other aspects of their testimony and the CON application. So Reggie, why don't you go right ahead and address the hearing officer and OHS staff.
Okay. My name is Reginald Silva. I'm the Executive Director for System Integrated Health. And before I touch on those specific issues, just want to give a quick overview of my background and how this project came to fruition. So, as stated in my testimony, I had a family member who attempted suicide back in 2019. I also take care of two of my nephews who are adopted has custody of them. Their mother is currently addicted to, well, she has issues with substance use, and last year their father passed away from a drug overdose. They're 13 and 14 now, but we've had them from the ages of 3 and 4. So I think those two kind of traumatic events, the attempted suicide and having to explain to these children why they're growing up without a father, kind of pushed me in a direction to change my career path. So I have familiarity with the state of Connecticut. I worked in the state of Connecticut previously before starting this venture. So I'm familiar with the Fairfield County area and the need for service in this area. So I just want to touch on SISU integrated health services and why I think our services are needed in the area. When putting this project together, the overview was really to create a holistic delivery of treatment. So combining substance abuse and the POCA, but really in addition to that, allowing more extensive wraparound services through partnerships with step-down levels of care, with focuses on holistic treatment like vocational profile, which we mentioned in our application, working with clients to build their resumes. So the thought process was, you go through treatment and you're sober, and maybe at some point you go to alumni where you feel like you're in a better space, but what coping skills or new skills are we actually teaching people in that process so that they can be productive members of society? And through my experience and interaction with people, based on the readmission rate, which in the Northeast is 85%, I tried to get a better understanding of people that had sobriety under their belt, what things made them successful. And I think things that we incorporated in our program are a reflection of the things that I learned from those individuals. So I think a few other things that make our services a bit more unique as far as holistic treatment is just our approach and process to treatment in general. So really having a robust programming and system around tracking clients from when they are initially in our care. So we're using a CRM to track, initial intakes or inquiries for service, and then having a repository within that CRM of either step down or step up providers that we partner with, so that we're really aligning clients with the appropriate services. And we do that with a system called Kipu CRM.
I'm
And-
sorry, I couldn't quite make out what that system is. That is what?
Kipu, K-I-P-U, Kipu CRM.
Thank
And
you.
that's really for all activity with clients up to the point of admission or referral. And then once we get to the point of admission, we use a system called Kipu EMR. So these two systems integrate. We're able to push clients from the CRM, which is a management tool, a client management software, and we can push them over to the EMR, which is really the more clinical side of treatment. And I'm going to have Kirsten elaborate on some of the more clinical aspects of Kipu EMR.
You would like me to do that now?
Yeah, if appropriate, I would just like to ask a follow-up question before we move to Ms. Clark, if that's okay,
Oh, yes, go ahead.
of the witness. Mr. Silva, could you elaborate on how the CMR allows you to track either step up or step down services when it's appropriate to refer a patient out of SISU integrated, how you've used it in the situations that right now you're practicing, it's clinical? Could you just elaborate that? Because I think it would help provide some context for the importance of that system.
Sure. So we're utilizing the system right now. We've been utilizing the system since July of this year to really track service inquiries and to track any of our either intakes or referrals. So we do our initial assessment on the CRM, and then we have a repository of partnerships, right? So we have a partnership with Paramount, we have a partnership with Stonington, we work with Hartford Health, right? Hartford Healthcare for the inpatient behavioral health. So New Beginnings Recovery for step down level of care. But we're able to house all of our referral partnerships in the CRM. And then based on our initial intake or our initial assessment, we have the ability to send clients to the appropriate referral partner based on their needs. And we've done that since July. It also gives us the ability to track this information. So we have a really clear understanding of how many clients we've referred out, where we've referred them, and then it allows us to kind of elaborate on that process as far as starting the client with us through their assessment, but then getting consent if they go to a step-up level of care, and really tracking them through that treatment so that when they come back to us for a step-down level of care, we have a robust understanding of how their treatment went and at the higher level of care.
And one more follow-up question in regard to that hearing officer for the witness. In terms of the holistic services, the wraparound services that in the completeness questions it was asked, are you now furnishing the services, all the services described at pages 10 and 11, not the Bates numbers, but the actual numbers for the agency of this initial CON application. Can you speak to those issues with respect to housing, legal services, and any context in terms of actual use of that?
Absolutely. So right now, based on our size and our anticipation of this certificate of need and licensing process, we've been able to provide the services that are reflected in our business plan, which are vocational profile, resume building, working with the community to help, maybe some incarcerated individuals. So resume building is a regular part of our programming. We have multiple clients with us currently who we've worked through resume building activities, put those resumes out into the market, and we're actually able to get them employment. We have clients who I was able to reach out to a bail bondsman, work closely with them, and communicated personally with a clinician for someone who was incarcerated, waiting for a bed, right, a treatment bed. So looking for substance use, higher level of care service. But instead of waiting incarcerated, I worked with the clinician to have him released and then released to our program so that we could treat him as opposed to having him, not get a treatment he needed and kind of wait for a bed. So I think those are some of the services that make our programming unique. And based on the feedback that we've gotten, I think that those are services that are needed, and I think those are services that clients appreciate, and that help them kind of build a new purpose after finding sobriety.
With that, I've at least concluded, we'll leave time obviously for OHS's questions, but I will now introduce Kirsten Clark, once again, the clinical director, who will speak to some of more clinical aspects of the care that individuals receive. And I know she wants to.
I just, sometimes it is difficult to hear you guys. If you notice me putting my ear towards the computer, it's because I'm trying to hear. So if you could keep your voice up while you speak.
do.
Attorney Cowherd, I can hear you loud and clear. It's just the other two. We're getting a little soft, and that's why I had to jump in and ask for things to be repeated or make sure I had the right letter. So if you
Yeah.
keep your voices like louder, that would really help me, because I'm trying to hear, but sometimes if you hear me if you see me sticking my ear towards the computer, I'm just trying to make sure I can continue to hear.
I appreciate it. We'll do that. We took care of the leaf blower, so we're,
Yeah.
we're moving ahead, and I hope that helps, but go right ahead, Ms. Clark.
Good morning. My name is Kirsten Clark. I am a licensed clinical social worker, and I am the clinical director for SISU Integrated Health. I adopt my pre-filed testimony, and in my testimony, I did reference that I have a mental health condition that was one of the reasons why I transitioned to working in Connecticut. I was diagnosed with a significant mental health condition when I was 19 years old, and it paved the way for me to become a social worker. As a social worker seeking services in the state in which I live, I encountered firsthand the barriers of access to care for myself and ultimately for my son. And I wanted to change that. So I left New York, where I was practicing, and came to Connecticut. I have been fortunate to work in this community for a number of years. I participate as a member of the community care team through Norwalk Hospital. I also have worked with Demas, and I am familiar with many of their processes and protocols. I am here because I believe in the mission of SISU Integrated Health. I believe in what we do every single day, and that is we strive to make a difference. There are many agencies in any state that you can talk about that can connect people to services by giving them a referral. We do more than that. We do what we're supposed to do as social workers and as providers. And that is we pave the way for the person to receive the service that they need. At SISU, we have never turned any client away that has sought our services. Instead, we partner with them with their consent to follow them on their recovery journey, even if that recovery journey requires that they step up to a higher level of care initially from what we can provide. Other aspects of our programming that make us different are the fact that Reggie mentioned our KIPU electronic medical record. In our electronic medical record, we have clinical assessments that we use to assess aspects such as trauma, anxiety, depression, substance use, etc. We are different from other agencies in that we use those assessments ongoing from the point of admission and throughout treatment up until discharge. Many other agencies only use these types of assessments at the point of admission and directly at discharge, which gives an incomplete picture as to how the person is truly progressing. Our process allows for us to change the client's treatment plan in response to what we are seeing in those assessments. ultimately resulting in better outcomes, which is what we want for all clients that we serve. The other aspects related to our system that I think set us apart is that we have such a robust level of programming that incorporates many different evidence-based practices, such as dialectical behavioral therapy, motivational interviewing, and cognitive behavioral therapy. But one aspect that definitely sets us apart is the use of cognitive processing therapy. CPT is a specific form of cognitive behavioral therapy that addresses trauma. Studies have shown that the vast majorities of individuals have experienced trauma at some point in their lives. Cognitive processing therapy is a condensed version of therapy that focuses specifically on trauma without requiring the individual to talk endlessly about the traumatic event. This allows the person to address their kind of maladaptive thought patterns related to that trauma in a safer way, so they are not re-traumatized. As a clinician, that has always been my goal, is to not re-traumatize any individual that I work with. I also think that our use of the psychiatrist that we have is extremely beneficial. All of our clients receive a comprehensive psychiatric evaluation within the first week of admission. That diagnosis by the psychiatrist cements what we are working with clinically and allows us as clinicians to, again, formulate and adjust the treatment planning as necessary throughout the time that the client is with us. It is my opinion that our use of a needs assessment is also a comprehensive factor that could be missing in many other agencies. This needs assessment asks clients questions about such things as, are you in need of medical treatment? Are you in need of legal support, vocational, employment? And we can then take that needs assessment and use it, as Mr. Silva said, to help them create things such as resumes or get into contact with an educational program. Through my participation with the community care team, I collaborate with other providers that are in the community. So if there are needs that a client has that we at SISU may not be able to provide, I can reach out to one of these members and help pave the way for the person to achieve those services.
If I may, hearing officer,
Yes.
Ms. Clark, could you talk a little bit more about your knowledge of provider networks and your work with provider networks through the Norwalk Community Care Team, and also just navigating the DEMIS system and working collaboratively with that state agency?
I'm sorry, can you clarify what you mean by provider networks?
Well, just who the other providers in the community who might be able to supplement the work that SISU Integrated Health
Sure.
is doing.
So some of the provider agencies that I collaborate with are Norwalk Community Health Center, the FS Du Bois Center. We also have collaborations with the area shelters, Open Doors, the Smilo Center. There's also even extending further into the Community Health Center, Inc., which, as you know, has locations all over. And then other elements such as Department of Social Services, Department of Public Health. In my work with DEMIS, in my prior position before coming to SISU, I worked with DEMIS specifically on housing and social programming for individuals with significant mental health conditions. So I was at the forefront of group home placement and congregate care settings. Does that answer your question?
It certainly does. Hearing Officer Novi, by way of explanation, because it's contextual to my final question to Ms. Clark, Dr. Ryan Joaquim, who is the employed psychiatrist with SISU, is seeing patients this morning. We knew it would be a conflict, unfortunately, but the issue with respect to the ongoing assessment and your work with Dr. Joaquim on treatment plans, can you speak a little bit about how that evolves?
Sure. So as I said, all clients within the first week of admission receive a comprehensive psychiatric evaluation. Then Dr. Joaquim and myself and our primary clinician, we meet and we discuss that evaluation. The goal is to ensure that the client is stable, that we are addressing paramount needs that we are seeing as acute when the client first comes into care, and that we are also ensuring that if the doctor prescribes medications, that the client is able to access and obtain those medications. As part of the process, the doctor continues to see them throughout their time in treatment. Typically, when someone first comes into care, he will meet with them weekly so that he can make sure that they are stable, that any medications he has prescribed are suitable for them, so that he can titrate them up or titrate them down, whatever the case may be. And as they become more stable, he reduces the frequency of those visits. But we as a clinical care team continue to meet and discuss throughout the client's time in treatment with us, what are the issues that we're seeing, how we can address them, and how we can best set the client up for aftercare when they leave our programming.
Well said.
I just have a follow-up question I'd like to ask because I have a feeling it goes to that. When you testified, you said that you track issues and assess throughout the process and change the treatment plan as needed. How many times, like approximately, does this occur?
In terms of changing the treatment plan?
No, doing the tracking and assessment of issues. Because most people do it on the way in and then on the way out, and you guys do it continually. I just wanted an idea of how many times that might be done.
Sure. So the date of the intake, the client is given initial assessments so that we can get a foundation as to where they stand with these particular aspects. Then we conduct it in regular intervals that occur with every 10 days. So the client is then receives those same assessments every 10 days, so that we're able to see on a very clear graph exactly where they're struggling still and where they're improving.
Great. And then one more question. You said that you also you do the psych eval in the first week and a needs assessment. The needs assessment, when is that done?
That is done at admission.
Okay. That was my follow-ups. Mr. Silva, I know you wanted to make a comment.
I was just going to add, I guess for tracking purposes and accountability with the doctors prescribing a medication, our drug testing protocol, as far as ensuring that medications that are prescribed are being taken, but also that people that are actively practicing sobriety are staying sober. And we have a protocol based on those drug tests. We have a protocol for what our action items would be if we either have a failed test or, and that's something that I've seen, whether or not there's a concrete process around it. That's something that I've seen in other facilities that I guess aren't as rigid with failed drug tests, right? So our policies and procedures, which you guys have access to, outline what our protocol is when somebody fails a drug test. So I think that that's beneficial from an accountability standpoint, because we're making sure we're testing every week and we're making sure that people are sticking to their treatment plan and people are taking a level of accountability for their sobriety.
All right.
Hearing officer, we're ready for the OHS questions. I just wanted to.
I think I'm gonna start with some questions. We'll go through as many as possible before we do a break. Is that okay with you?
Certainly.
And to my and to the staff for OHS, if any of you do need anything, please feel free to just let me know. All right. So I'm gonna start with some easy questions, and then I will move to some that are more difficult to answer in multiple parts. The first question is, what does SISU mean and stand for?
What was the first part, Stan?
What does the company name SISU mean and stand for?
It's Finnish, and it doesn't directly translate to English, but it's the closest would be like resilience. It's a Finnish spirit to kind of overcome anything.
The second question is, were there other regions of the state that were considered for establishing SISU? And why were these areas not selected as a facility site?
Were there other areas considered
Or sorry, of the state of Connecticut?
of the state? Not at the same level, I guess not at the same investigatory level as this particular area, because I was familiar with Fairfield County.
Okay. In your application, you state that you will have a 5% Medicaid population. If a new patient shows up and you have already reached 5% of your allocated slots, what happened?
So the 5% that you're referencing, I just want to make note that I actually listed it as 10% in another area, so that 5% in that particular response is a misprint. But really our Medicaid population will be 10% in the first year, and then a reflected percentage growth over the next 3 years. But that's really a bottom line threshold for us. So we'll have a minimum of 10% in the first year, and then as we grow, we bring on a greater census. We have a little bit of a more robust user mix. We bring in revenue. Then we'll be able to grow that percentage over time as the business grows.
And just for clarification of staff, that's table 9 of the CON application where the correct percentages that were referenced by the witness.
I am taking notes in written format, so if you see me looking down and I don't respond right away, it's because I am writing them down by hand. All right. So for our next question, it says in Exhibit A at page 45, you state it is anticipated that IOP will operate without adding significant facility fees. What does this mean?
Okay, facility fees. So my understanding, I guess, at the time of the facility fees were additional fees. So our intent is to bill for day treatment. So IOP and PHP, we're not looking to, I guess, bill for ancillary services.
So will there be a facility fee charge for IOP treatment?
A what charge? I'm sorry.
Will there be there was a lack of clarity and definitiveness in some of your answers. So I'm just trying to get down to a definitive answer. Is there going to be a facility fee for IOP clients?
A facility fee? No.
Okay.
And the costs and expenses, hearing officer, are provided with respect to the follow-up that was in the completeness questions as to what will be billed and what will be collected.
Okay. What types of payment options will be presented to uninsured patients? A sliding scale was mentioned in the application, but there wasn't one provided. If it's something that you can't answer right now, that is something we could take as a late file.
Okay,
You mean the charity care policy of the center?
Well, they do mention that a multitude of types of payment options that could be provided to a uninsured patient, and it did mention a sliding scale. I did not see that anywhere in the submitted materials. So I would like a little more, again, a definitive answer to what would be provided to an uninsured patient looking to obtain services. And if you'd like, that can be a late file.
okay,
Speak
without going back to it, I think that the intent was to incorporate the charity care into the policies and have a sliding scale, but I'd have to go back and I'd like to submit something that outlines that definitively.
Okay, so we will make that late file B, will be the submission of that. And that can incorporate all, I know that it was mentioned throughout that there would be a sliding scale, but that could include whatever other options that would be presented to them as well. So if there was anything else that would be presented to an uninsured client, you can just include that as well.
Okay,
And just for clarification, hearing officer, as the agency may know, with respect to behavioral health especially, there are self-pay patients who have insurance but do not wish, for a variety of reasons, for the insurer to cover those expenses. And are you referring to just pure no insurance, or should we also speak in the late file with respect to self-pay, which, at least in my practice, I've distinguished along those lines, but I
would appreciate both if you could include.
Okay, very good.
Now this may go to a little bit of what I have asked Ms. Clark about already. So what I would, it says in Exhibit A of the CON application on page 68, it discusses advanced tracking of patient outcomes as a cornerstone of the proposal, because data will allow for informed decision-making in the facility, such as cost shared savings reimbursements, improved performing within value-based payer models, and can help SISU participate in risk-based contracting. As such, can you please identify the software that will be used within the facility to store the data and analyze it and monitor the effects of the implemented changes?
so the software that would be used would be Kipu, and it's specifically what we were just referencing, or the highlighted areas that you referenced. I think the best representation of those would be in the Kipu BI.
I'm sorry, that's B as in boy, I as in igloo?
Correct.
Okay. All right, and then please detail the patient outcomes intended to be tracked and describe how the outcomes will be measured within the software mentioned.
Kirsten, would you like to take that? I'm done.
So some of the aspects that we would be tracking would be, as I already mentioned, the anxiety, depression, trauma, etc. But then also we would be looking at aspects such as client satisfaction. We would also be looking at elements related to, elements related to aftercare, such as pieces related to if they came in and they didn't have housing, do they have housing when they leave? Do they have stable medical care? Are they engaged in purposeful, productive activity, which could be defined differently for each person, depending upon their life circumstances. So perhaps it could be volunteering, it could be attending another social support program, it could be employment. We would also look at elements related to attendance across time so that we could determine if our programming needs to be adjusted in terms of time limits in which clients are in treatment with us. And we'd also look at how they are doing post-discharge by following them every month for the first 90 days, and then continuing to follow them with regular check-ins after that. Depending on circumstances. So if in that first 90 days, we determine there's a higher level of need, we would follow them more frequently. We would not transition them to, let's say, a 6-month follow-up if they were still struggling. We'd also look at things like connecting them, to our alumni support so that they would be able to continue to have peers that they may have been in treatment with or who had been in treatment prior to them coming there that could, continue to help them in their sobriety or in their mental health stability.
And who in the will be responsible for entering this data into your HIPAA BI?
Go. Do you want to take that?
I think so. It's like there's a multi-level there, depending on where we're pulling the data in. If we're doing a client survey, then a lead clinician can do a client survey. If we're doing alumni data, right, then an alumni specialist or an admission specialist would update that data. We're talking about specific outcomes, and then that's something that the clinical director would input.
No, who would be responsible for analyzing the patient quality, would be responsible for analyzing patient and quality data that is entered through this system?
So part of our, I guess, improvement plan. So our intent is to go in front of Drug Commission, right, and get accreditation. So what we're rolling out now is clinical meetings to start reviewing the data so that we can make higher level decisions about how we tailor programming to better serve clients. So we have a quarterly executive clinical meeting where we review the data that we're speaking to.
Okay. Now, you just mentioned that you're going for Drug Commission accreditation, or you would like to go for that. Are you in the process of that right now?
We're not yet.
Okay. When do you intend to?
After we get our licensure.
I'm sorry, I could not.
After we receive our licensure, so once we're licensed, we'll start the process.
And how long do you anticipate that process to take?
So my experience with the Drug Commission has been that they come out in year one, they do kind of an assessment. They look over your programming, they look over your policies, they make up an action item list of things that need to be corrected, and then they do a follow-up. Either 12 months or just short of 12 months in the second year, and look to review all of those action items to make sure that you've improved your programming and addressed some of the issues that they've laid out. So I think it would take us, that would be the timeline.
Okay. Now, the patient outcomes that you are tracking, how did you determine to select those items?
Those particular patient outcomes?
Yes.
Some of the outcomes we reviewed, and I can point to specific areas, but there's a need assessment for the Southwest region of Connecticut. So I think we identified some of the need assessments And then we've built that into our needs assessment. Other metrics that we're tracking, we worked with people that had years of aggregating this data, like the software company, like Kipu. And the other things that we're measuring, and really the clinicians had a high level of input with the MD.
I think, just to jump in, I think part of the reason why we chose.
You could just state your name, I'm sorry, so that the stenographer who's typing and not viewing this could
Oh,
just state your
sure.
name again, I'm sorry.
This is Kirsten Clark.
Okay.
I think part of the needs, excuse me, part of the reason we chose some of the assessments that we did is because in the needs assessments that have been conducted, there are identified as high rates of anxiety, depression, and trauma in this particular area. And there's an unmet need for those services. So it would make sense that we would be tracking those because we want to make sure that we're effectively addressing those elements so that it does not become a revolving door to care where clients are not having their needs met. The other aspect is when clients come into treatment for whatever the issue is, be it substance use or behavioral health, they oftentimes come into care not having structure to their life. Their entire life is about navigating their substance use or navigating their behavioral health. So things like paying attention to bills or paying attention to housing or employment kind of fly out the window. So that purposeful productive activity element that I measured is key because that shows that the client is receiving benefit from the care that is provided. Additionally, there are multiple research studies that you could look at that talk about the importance of individuals as they enter recovery, having structure and activities throughout their day as a way to maintain stability.
Now, I would like to give you a chance to submit further data or peer-reviewed research which shows that the tracking of those advanced patient outcomes has led to improved treatment adherence and health outcomes for the patients. So if we could do that as late file C. No, this is only our third late file so far, but we'll have a few more. We will get to probably an E, but we'll call this C. Okay. So if you could submit any studies or the Southwest needs assessment, anything that you feel would be relevant to that the decisions that you made as a company. I'm going to switch gears a little bit. On page 29 of Exhibit A in the application, it states SISU has integrated health services to expand access, allowing patients to engage in therapy sessions, receive medication management, or attend peer support groups remotely, which is also beneficial to individuals with mobility challenges. How will this service be integrated with in-person services?
How will the virtual service be integrated with in-person services?
Yeah, virtual / telehealth.
Yeah, I was going to ask for that clarification. Thank you. Either of you can take the telehealth, but thank you.
So clients can join a group session via telehealth. So we run a group similar to what we're doing right now. So if a client wanted to call in for group because they were unable to make it to the facility, they would log in and they'd join the group via telehealth.
So would this, so what would the integration of the telehealth services look like with an in-person plan? Would this be an optional thing? how would a patient integrate? What would their interaction with these services look like?
About interaction with services, but the integration, and I guess when it's applicable, we try not to, if we can't find another facility or if a client's not mobile, that's when I think it's applicable. We really try to have everybody on site. I think that's when we get the best, when clients get the best treatment. But I think that's when it should be utilized or when it can be utilized. I think, yeah, this is Kirsten Clark. Yes, I think, can you just, I'm sorry, going back really quick. Can you clarify what you mean by interaction with services?
It's the question is, how will this be integrated with a person in services? So I get that you'd prefer them to be in person, but if somebody say it's snowing, they can't get there that day, how would that look like for them to access? Could they, their group session or? Sure.
So what happens is we send out a link through our electronic medical record. The client gets an email, they click on the link and they are able to participate in the group. The clinician and the other group members sit in the group room. There's a television there. So anyone participating virtually can see the clients in the room and the clinician, and the other clients and the clinician can see the clients participating virtually.
And will there be certain staff members that are just assigned to provide telehealth, or is this offered at any time?
Yeah, so I think it's certain clients it would really be if there's a client that for whatever reason can't make it into treatment and we can't find, whether that be geographical and we can't find them an alternative that suits their need, then we would utilize telehealth.
Hearing Officer Noby, if appropriate, I'd like to ask a clarification question that I think is relevant to this whole topic. Mr. Silva, could you speak more to when you'll make your programming available so that there will be more live participation in terms of how often and when you'll offer the services of the PHP and IOP programs, meaning nights?
Oh, that line of when the service, so not virtual, we're just talking about programming.
No, that's I think what the concern of the agency rightly is that it's all telehealth, and I want to just talk about availability for people to access your facility.
Our preference isn't telehealth. Our preference is to deal with people in person daily. I think telehealth is a good resource for people that don't have access to this type of programming. If the alternative is no access to treatment or telehealth, I think those are the instances where we would utilize it. But because we utilize it inside of KIPU, any group, we have the ability to set any group. So if you're coming on a PHP level, you're coming to a group in the morning for 3 hours, we have the ability inside of KIPU to turn that schedule virtual for that one client for that one day. Same thing with the follow-up group in the afternoon, and same thing for a night group.
One more, will there be programming after work hours? Will there be weekends available to these individuals?
Yes, night. So we're planning on operating programming throughout the day, right? 6 days a week. So one session in the morning, one session in the afternoon, and then a night session. And then we plan on doing Saturday programming.
So Sunday would be the one day you don't offer programming.
Yes, ma'am.
Okay. And what would be the latest you would offer programming on a weeknight?
Daytime.
On the weeknight,
Yes, you said nights and weekends, but, and I know you'll be offering Saturday, but what would you hope to have as a night group?
so a 3 hour, where we're trying to allow clients so that they can meet the hour minimums for certain levels of IOP or PHP. So it would be a 3 hour group in the afternoon. So 6 to 9 o'clock, 5 to 8 o'clock.
All right, I'm going to transition again. And I'm going to take you to back to exhibit. We're going to stay with exhibit A, but on page 70 of the application, you state that existing facilities are often at full capacity, leading to wait lists and delays in treatment that can be detrimental to patient outcomes. What evidence is available to support this statement?
Since we've been in making our services available to clients, we deal with a bed availability and utilization every day. Clients call in, and if they need a higher level of care, we're, as Kirsten referenced, the ability to navigate the DEMAS website. So we're looking on the DEMAS website, looking at bed availability, seeing if we can get them into a higher level of care. That's the appropriate location for them to attend treatment, or we're working with a referral partner. But a lot of times we don't have bed availability. In those instances, we work with the hotline on the DEMAS website, and we'll stay on the phone with a client, ensure that they get an intake date that day. So for like the following day, right? No bed availability today, we'll do their intake with the hotline. We'll get them into a facility for the following day, and then we'll follow up and make sure that they get there. But really, from our experience, it's on a day-to-day basis. I mean, we're looking at this, we're looking at the utilization rates and the availability, bed availability.
Do you have any written studies or information that you could point me to that would be?
With respect to the availability of just general, mental health at the PHP, IOP, or inpatient level, we can provide that.
Yeah, so let's make that late file D. And that's inpatient.
Did you want to speak to that issue?
I
Ms.
think.
Clark, go ahead.
This is Kirsten Clark. So in reviewing different community needs assessments, there's documented evidence that in the state of Connecticut in particular, when we talk about different levels of care, I can speak specifically to residential. State beds are typically occupied at a rate of 90 to 95% most of the time, which makes it challenging for people to obtain services. The other element is that, if we're talking, for example, Norwalk Hospital, while they do have a psychiatric unit, it's very small. And so a lot of times when clients go in crisis, they may be kept in the emergency room until a bed becomes available. The other elements are that there are IOP services here in the area, but there's a lack of PHP services. So if a client, and I know that because I'm trying to find PHP services for clients by calling different agencies. And while IOP is a resource, Norwalk Hospital has an IOP, there's different locations, other providers, Connecticut Counseling has an IOP, for example. There's not a lot of PHP. It's just not available here.
Thank you very much. We'll do that as a late file D. I am going to move to the exhibit D now, which we've already discussed a little bit, and we can also do this as a late file if you'd like. Actually, I will ask for this as a late file. In the opposition letter by the Connecticut Center for Recovery, 10 existing providers were mentioned. I would like you to please revisit your answers to OHS Table 11, the services and service locations of existing providers of page 64 of your of Exhibit A. And if you would like to, please provide that as late file E.
Is that F?
Nope, that's E. We finally made it to
Okay.
E. D was
Okay.
the PHP services, so.
Oh, okay, okay, I understand. Yep,
So we will go ahead and I would like you to resubmit table 11 in light of the fact that they mentioned more providers than you did in your original filing.
absolutely.
Okay. All right. My last are actually my last few questions will come off of some of the what Miss Clark hit on earlier today. On page 5 of Reginald's pre-file testimony, it indicates participation in the Norwalk Hospital Community Care Team. Can you please elaborate first on what is the team and what is the goal of this team?
Sure. So the community care team's goal is really to help vulnerable individuals obtain services and supports that they need, so that they don't kind of fall through the cracks and kind of become without services. The system of care can be very challenging for someone to navigate if they don't understand the various ins and outs, which is why I think so many people go to emergency rooms for care, because that's their first line of defense. But the Norwalk Community Care Team is a group of providers from throughout different areas. As I mentioned, there's Department of Social Services, FS Du Bois, FS Du Bois, DSS, Westport Shelter, the police station, etc. And we all come together once a week. There is a set list of clients that is discussed with everyone on the meeting kind of sharing, options and resources, education and information to really make sure that those individuals that are discussed continue to remain as stable as they can. The resources available within the community care team are extensive because of the large number of agencies that participate at any given time. So, the ability to connect someone to a level of care or to housing support or food stamps or whatever the issue might be is really useful. The other aspects that's useful is through our collaboration, we can reach out to one another offline from that meeting and say, this is the issue I'm having, can you help me with it?
And what types of actions does the team normally take?
I
know you mentioned housing, food stamps. What kinds of things could the team do if they determined something was needed for a client?
So some of the things that could be done would be, for example, for someone that might be overutilizing the emergency room as a form of treatment, a plan can be put in place to make the emergency room less appealing to the person. For example, a lot of times when people go to the emergency room, they're given cab vouchers, they're given snacks, that they're able to socialize. So the emergency room might put into practice, like, well, you've come here multiple times today, because that happens. They may put in, say, we're not going to give you a cab voucher. They may say, instead of giving the person snacks, they may, help them instead to access food stamps as a way to kind of make it less appealing to go to the emergency room.
And how often does SISU engage with this community care team?
The community care team is a weekly meeting.
So you're at the weekly meetings?
Yes.
All right. Just review my notes. That is it for my questions at this time. So what I'm going to propose is we take a 20-minute break. We'll come back and allow for follow-up by Attorney Cowherd. Then we will go into to public comment and closing arguments. Does that sound like a good amount of time? Do you need a little more time, Attorney Cowherd?
No, I think 20 minutes shall suffice. Are you speaking for the analysts as well, that OHS questions are concluded?
I'm going to meet with them during the break. We may have additional questions after the break, but I want to give you a chance to get yours together, because right after that, after our analyst had a chance to get theirs together, if they have any, we'll roll right into your questions. So. Okay, very good. If that's the case, because I was a little confused by the agenda on that, can we have a half hour? Oh, yes.
Is that appropriate?
Yeah.
Because there's been a lot said.
Why don't we come back at 11 a.m. For the finish up with analyst questions. Then we will go to Attorney Cowherd's questions, public comment, and back to the closing statements.
I appreciate the extra time. Thank you, hearing officer.
We will now take a break until 11 a.m. Thank you, everybody.
All right.
Thank you.
Bye, everyone.
Thank you.
All right, as Zoom has just notified you, this hearing is being recorded. If you do not wish to be recorded, you can revoke your consent right now by exiting this hearing. All right, seeing as nobody has done that. Good morning. It is now 11 a.m. and I'm going to go ahead and resume this hearing. I'm sorry, we have all been referring to this wrong. This is SISU Integrated Health LLC 24-32709-CON. This they seek a CON to establish a psychiatric and substance abuse treatment outpatient clinic in Westport. We will now be calling it SISU instead of SISU. I apologize for that.
Thank you.
Right. We do have some follow-up questions we just want to go ahead and ask first, and then we will go into your questions, Attorney Cowherd. My first question would be, is Medicaid going to be accepted for all proposed programs?
For all the programs that we offer, yes.
Okay, so Medicaid recipients across all services, including IOP, OP, and PHP, will be able to apply and enter those programs with Medicaid?
Yes.
Okay. Will you adhere to the non-discrimination provisions of the DSS provider enrollment agreement? PHP is we do know that PHP is reimbursed by DSS at a lower rate than IOP and OP. We just want to make sure that you are going to be providing those services through Medicaid.
Yes.
Okay. All right. And then we have one additional question, different area of questioning. You mentioned, or Ms. Clark mentioned a facility that sounds like FS Du Bois.
Yes.
Can you restate the name so that we can all get it on the record correctly, and then tell us what that is?
Sure. It's F as in Frank, S as in Sam, Du Bois. And they are, sure, it's D as in David, U, B as in boy, O, I, S as in Sam.
And what are they?
So it is a state agency connected to Demas that provides mental health treatment.
All right. That is it for our questions. Thank you for clarifying that for us. We weren't quite sure we heard it correctly, and then we weren't quite sure we spelled it correctly, and also had a question about what it did.
Certainly.
Okay, and with that, Attorney Cowherd.
Well, thank you, and thank you for your time and attention so far in this opportunity. I'm going to just dovetail off what the hearing officer just asked you about. Reggie, could you, Mr. Silva, could you speak to interaction thus far with Department of Social Services in terms of Medicaid and Department of Mental Health and Addiction Services in terms of any interaction thus far, you know, since you've been in operations in Westport?
Sure. So right now, because we're not licensed, we are really not technically able to register as a facility with DSS. However, our MD is currently credentialing with DSS. We use an outside agency called Abacus, and they're working through the process with our medical director at the moment to ensure that he's credentialed. As far as our involvement with Demas, to my understanding, I mean, we've reached out to Demas, we utilize the site, and just for broader visibility, we've reached out to see if maybe we could have our services listed on the site. And I think that that's really, based on what we do, I think that that's really the only thing that we could do. But if there are other things that we can do in conjunction with Demas, we'd be open to doing that.
And the purpose of listing your services with Demas is for what purpose from the agency's point of view?
From the agency's point of view, as far as
Resource.
having a resource to access our services.
Yeah, just one. Mr. Silva, you mentioned during the break the charity care policy, and I want you to speak to that for a moment. We will furnish the late file hearing officer, but I wanted the opportunity for the witness to speak to that.
Can we come back to it? I just want to pull it up.
Okay, all right. Not to spoil the ending, but there is a policy and procedure that was submitted as part of that voluminous policies and procedure. Let's give you a moment. I'm going to give you a moment. I'd like to speak to need with Ms. Clark. First, in terms of your living in this service area, in terms of when you first started, just by context, in terms of need, can you speak to just elaborate on dates and so forth?
So I moved with my family to Connecticut in 2011. I did some private practice work, and then I started working at a federally qualified health center right in Norwalk in 2015. So in terms of need, I've seen it throughout my time in Connecticut in my attempts to connect the clients that I've worked with services related to PHP and IOP. And if you reference some of our support letters, specifically the ones from High Focus and Norwalk Hospital, these are entities that provide similar services to us, and they also are attesting to the need for more PHP and IOP services in the area. I would also like to say that there's a part in the Norwalk Hospital letter where she talks about their psychiatric unit and the ability to provide a seamless integration of services upon discharge from inpatient to outpatient with an additional provider in the area, which is ultimately what we want to have happen, because we all know, or studies show as well, that when clients are discharged from an inpatient environment and they are not connected immediately to an outpatient level of care, stability can fracture, motivation can fracture, and everything that person has worked so hard to attain in the inpatient setting is at significant risk. So I think those elements all together really do cement the fact that there is a need in this area.
So,
You said you want to speak to.
Sure.
Yeah, go ahead.
so, right here, we say that we have a policy that provides scholarship assistance to qualified individuals in need. SISU Integrated Health will reserve. So we make a reservation of the net profits, 3 to 6% net profits for IOP, PHP treatment services for charity care. Profits are determined quarterly and compounded if not utilized by the executive team, who will identify candidates via financial assistance applications by prospective clients. That's what we're referring to, the charity care.
That is an exhibit to the completeness questions, hearing officer. We will speak to that in practice in the late file.
Thank
Okay.
you very much. I do appreciate that. Attorney Cowherd, any additional questions?
Yeah, I do have a couple. Mr. Silva, you spoke early on about the personal experience that you had with respect to mental health, suicide prevention, any substance abuse. Speak more to the career change and what your former career and background brings you to, and what you feel benefits your executive directorship of SISU right now.
Okay, so from a service perspective, I think my previous experience from a service perspective isn't directly applicable, but I think that the managing or managerial aspects, planning aspects of my previous experience in a different field are directly applicable, just from the aspect of, Kirsten alluded to this earlier, but people having structure, our team and our staff having a clear understanding of the programming, having policies and procedures, which we worked extensively on, just a more methodical approach to our structured business plan and the layout of the programming. And I think through, I'll mention that the prior experience is good construction management, but also just attention to detail through military background.
Thank you. I'd also like to speak about and have you speak about how that entails the sort of scale-up plan that you provided as part of the responses to the hearing issues, and in particular, the idea of 10 to 12 patients per therapist, why you've chosen that model.
Sure. So I think based on the suite of services that we're offering, which I know that we spoke about just billing for PHP and IOP, but obviously those aren't the only services that we're providing. So providing holistic services for all of our clients, and providing holistic services, but not overloading or overwhelming your clinical staff, right? So I think that number is appropriate based on my experience in this field. So I think that that's a sound growth strategy without actually overburdening the clinical staff.
And speak to, in terms of that, in terms of billable and collection, the holistic services that you may provide that would not be reimbursed under typical PHP and IOP.
Correct.
Okay, and could you name a few of those and, you know, what you provide holistically? What Kirsten spoke to in terms of, you know, other resources in the community?
Yeah, so vocational profile, resume building, we're really not looking to bill for any other services. I know we have MAT in there, but we're not billing for anything but PHP and IOP, but we're providing a suite of services. So, I mean, yeah.
Also tell me, and tell the agency more importantly, about the relationship with New Beginnings and Paramount, if you could, and the full names of what they do for the agency's benefit.
So in developing relationships and referral networks with a step down level of care, step up level of care, higher levels of care, we developed a relationship with New Beginning Recovery, who primarily focus on sober living for clients. They've evolved their business model over the last few years, and I think next week is their 10 years in business, right? So they've been in the area for a long time, they've been servicing the community for a long time, but I think adding some of the holistic qualities that they're adding to their programming really aligned with our vision. So the sauna, cold plunge, the nutritionist, really focusing on getting people back into the community and working. We were able to build a really strong relationship with them because I think that our services align with their approach and their methodology for treatment.
Yeah, and with respect to Paramount, can you speak a little bit to them?
Sure. As far as, so our capital expenditure was significant. We spent over $300,000, and we renovation cost a facility that we fully renovated in Westport. And, you know, in addition to our services and the quality of care, and I think the comfortability of clients and the space that we've been able to develop, we thought that Paramount's facility, approach to treatment, quality of service was congruent with ours. So we've worked, I don't want to say extensively, but extensively enough for what our client census is now with them, because for those reasons.
Yeah. Speak to the development of the policies and procedures and your initial approach in terms of interaction with OHS and how you worked with Mr. Krulik or others with respect to policies and procedures.
Okay, so in the development of the policies and procedures, we actually we outsourced to some extent. We worked with a vendor to develop the policies and procedures specifically for behavioral health. And we got those policies and procedures to a point where we thought an outside agency could really bring them, but on the managerial side, we worked with Brian to really build them out so that we thought they were all encompassing and they covered our approach and our business approach to this level of care and to this treatment.
And your initial contact with OHS, why was that initiated?
OHS on the website provides a service where you can have an initial meeting with the members of OHS. So I think early on when we were putting the project together, I reached out to Steve's office and met with a few individuals from his team just to kind of better understand the certificate of need process and kind of understand the people that were going to be involved from the OHS side.
I wanted to finish on both of those because the policies that were produced are voluminous, and we understand that it may take some time for your analysts to get through them, but they are all encompassing, at least from my experience, hearing officer. And the second thing is to really commend the agency with that resource that when the client approached me, he spoke so highly of. So with that, I am done with any follow-up questions unless my follow-up questions elicited further questions from you and your staff.
I have no additional questions. I'm just going to give the analysts, if they have any additional questions and they want to throw them into the chat right now. I am not seeing any. All right. Thank you, Attorney Cowherd. I do appreciate your follow-up questions. We can move into the public portion. We can go right into that if you would prefer, or we can take a quick break. Are you amenable to us proceeding right into public portion?
Yes, we're fine.
All right. So at this point, we are going to go to the public portion of today's hearing. For we've had sign-ups this morning. I have checked in with our person who's handling all of our technical issues. That is Ms. Fentis, and she said we have had one sign-up, and that sign-up was Peter Rockholtz would like to offer public comment. I will note that we have received your letter. It is in the record, and we would prefer that you not reread the letter now because your letter is in as an exhibit. So if you would like to make additional comments, we will call the name of the person who signed up to speak in the order in which he registered. After that, I will ask if there's anyone else present who wished to be heard. Speaking time is usually limited to 3 minutes. So I will allow you to go slightly beyond that. However, I will ask that we stick to the time limits as you have already submitted additional comments. I would like to just let everybody know we strongly encourage you and anyone listening to submit written comments to OHS by email or mail. However, it must be received no later than 1 week. So email is the fastest and most efficient way to do that. 7 calendar days from today. And our email address is concomment@ct.gov. Again, that is CONCO, M as in Mary, ENT@ct.gov. Our contact information is on our website and on the public information sheet, which is provided on our website as well. I would like to thank everybody for taking the time to be here today and for your cooperation. I will ask that whoever does speak, utilize their turn their microphones on when they're called and their video camera. When not speaking, you can turn your microphone and your video camera back off again. All right. So at this time, I will go ahead and call Mr. Rockholtz. Good morning, sir. If you could please state your name.
Good morning, Hearing Officer Novi. My name is Peter Rockholtz. Last name is Rockholz. I'm here today as the Executive Director of the Connecticut Center for Recovery, CCR, and I've been asked by its CEO, my boss, to ensure that the letter that he submitted as Exhibit D was in the public record. And I did submit an additional letter on my own at the request of Mr. Lavolsi just to follow up. And I just was not planning to speak, but just wanted to comment on a couple of things that were said. So, obviously I'm not going to review those letters. They speak for themselves, I think. So I'm not an intervener. I'm not an attorney. I'm not the party. I'm here to give public comment as a concerned provider. And so I just want to ensure that the concerns that were expressed in those letters are considered and questions are considered. And I just wanted to respond to Attorney Cowherd's comments about the letter and the motivation for the opposition from CCR. Yes, absolutely. I drafted that letter of Exhibit D for Mr. Lavolsi. He reviewed it. I redrafted it, and he signed it. I can Apologize for apparently sending in a copy that was unsigned, and I can certainly, if requested, submit the signed copy. In terms of the question about motivation, I think I'll just give you a little idea of why I've been asked to provide this comment. When the SISU application showed up in the portal, I received 5 calls from different providers in Connecticut. I tend to get these calls because they know that I am extremely familiar with the entire system of the state of Connecticut. I've been a provider of behavioral health for 51 years.
If I may, hearing officer, I appreciate Mr. Rockholz and his right to provide public comment, but he's not staying within the confines of his letter. I'm not going to readdress what he's saying, but I just think that he submitted a letter, and his comment should go to what's in the letter, not anything else said. We'll provide our reasons for opposing Exhibit D, and as I said, the agency can then determine on its own the propriety of that. But with that, I normally would not say anything, but I think this is, sort of that cross purposes of, a member of the public who has submitted a letter deviating off that letter. That's all I'll say.
Okay, I'm going to just remind Mr. Rockholz that he did submit a letter. This is public comment. So, and I don't believe you are here testifying or attempting to testify. So we'd love to hear your comment that you would like to make. And don't forget, I'm allowed to give anyone's public comment the weight that I deem appropriate. So do you have, Mr. Rockholz, a comment that you would like to make? And
Yeah, sure. And it's really to elaborate on the points made in the 2 letters. And it goes to duplication of services and lack of need, and the negative impact on other providers. So I think one of the questions, and I'll try to stay to the point. So I think one of the questions that came up in the testimony earlier was a question about the need in terms of other facilities, and it was suggested that the other outpatient facilities have wait lists and are full, but the response by the applicant was about beds. And so I can just say that the reason that this letter talked about that was that there are numerous other facilities, some of them not mentioned in the application, that are the reason that I was asked to speak for several providers that, for example, in addition to CCR in Greenwich, Blue Sky in Danbury, Anxiety Institute in Greenwich are up and running with PHPs. There are several IOP programs. There's three others in Westport, one in Wilton, a couple in Norwalk. There also are a couple that have already been approved, including the Dorm in Stamford and Lantana in New Milford. And there's an application awaiting a decision by OHS on Sound Recovery in Bridgeport. So basically the point here is that I was translating in the letter is it's very crowded here. There's an overlap of services, and it's important to say that part of the reason for that is that we're talking about service areas that are overlapping. So on behalf of CCR, 75% of our clients for PHP come from the same service area that the applicant is proposing, and there are other overlaps with all of these other providers. So I think rather than talking about beds, bed utilization, the question wasn't answered about the utilization of these services that I'm speaking to. And that's really pretty much it, other than I just There's an additional question that was not in the letter that concerns that came to me about the applicant essentially, and I think it was clear in the testimony, questions and concerns by CCR and others that the applicant has been operating as an outpatient facility as they described here without a license and without a certificate of need. I think there's a misunderstanding that you don't have to have that unless you provide IOP and PHP, and that's not the case. So that's really all I have, and I appreciate the opportunity.
All right, thank you very much, Mr. Rockholtz. At this point, I will ask anybody additional who is in this hearing, if you would like to make a comment, please type a note into the chat right now. I'll give you a quick minute to go ahead and do that. I see nothing more, and I have no additional comments from Ms. Ventus. She just said no more sign up, no additional signups. So at this point, I will go ahead and I will thank everybody who spoke for public comment. We will continue the technical portion in which we will now talk about the late file exhibits. Attorney Cowherd, how long do you think you guys will need to get the late files together?
A week.
Would you like more than that, just in case it does take a little time?
You gotta make the Columbus Day.
Okay. 2 weeks.
Let's do 2 weeks, just out of abundance of caution, hearing officer.
You know, I do appreciate taking a little extra time because you can come back and ask for more time, but I prefer you give yourself enough time to get everything without having to rush. So we will have
this been doing this too long to rush things along, but
yeah.
just an aside.
So we will have late files due on by the close of business on October 23rd, which is a Wednesday. Is that okay?
Yes.
Again, Attorney Cowherd, if you or your client find that you cannot get those in by that day, you're always welcome to contact our office and request a later file date. At this time, I will go ahead and issue an order that the items I'm going to list will be and I will send this out as an order as well after the hearing to you so that you have this, that they produce as late files by the applicant, and that they be produced by the end of the close on October 23rd. Let's quickly go over them. They will be in letter format as well after this hearing. All right, I do have notes on multiple pages, so I want to make sure I go back. Late file A will be the applicant's response to exhibits D and S. Late file B is the submission of self-pay and uninsured patients. The options that will be offered to them for payment and charity care and a sliding scale if there is one. Let's see. Late file C is providing data, peer-reviewed research, or other documentation that demonstrates that the tracking of advanced patient outcomes leads to improved treatment adherence and or long-term health outcomes for patients. Exhibit D is the late file for what evidence is available to support the statement that existing facilities are at full capacity with wait lists or delays for treatment in IOP and PHP. Late file E is the table 11. I'd like you to revisit that. And that is it. Again, I will produce those in an order for you after the hearing. And that will be sent to your attorney shortly thereafter. And with that, we will go ahead and move to closing arguments or statement from the applicant's attorney, or actually Attorney Cowherd, do you have anything you'd like to say before we go to a closing statement?
No, not at all.
With that, your closing statement or argument?
Okay. I will note that in the public comment period, there was no comment from the public as to lack of need. I will note that in the letters referenced as to duplication of services, availability, that there was no intervener that was willing to be cross-examined and asked about those issues. So I'll start with that. Hearing officer and OHS staff, I'm going to take a little bit of time here because I want to be as methodical as I believe this client has been in approaching OHS with this application. Even though, as I said, this application was not filed after October 1. And I think in my years of practice, which are substantial in front of this agency and its predecessor, I've never seen a more personalized CON application, first person, et cetera, being used. But I wanted the 2024 statewide healthcare facilities and services plan as part of the record, even though the client SISU submitted, I call them SISU, it's just easier acronyms for me. But with respect to that, they filed before October 1st, but I wanted to focus on the standard and guidelines in chapter 6.7 that I think is more relevant than the 2012 plan to what the state of mental health and substance abuse need is in the state of Connecticut. And for that need, we only need to turn to the plan itself. In the key issues section at page 18 of the statewide plan, it cites an increasing prevalence and need to treat and manage behavioral health care conditions, mental health, and substance use disorders that will impact the need for behavioral health care services. At page 162 of that same plan, OHS found that that there were more than an estimated or thereabouts 581,700 adults. We're targeting adults. The mention is made in that CON application about the prevalence, and it is skewed in some of these other facilities, which you've asked for, and we will provide toward adolescent care. This provider is 18 to 64 and has provided the data in its CON application as why it has that wider group. So we're talking over 500,000 people in Connecticut that had mental illness and a need for treatment in 2021, with the rate of serious mental illness in the plan for adults 18 and over continuing to climb. That's figure 6.1 of the agency's own plan. And when interested parties speak as they just did to need, and then testify on behalf of a provider in the service area as to need, I'd like the agency to take that into account. You just heard recently Sound Recovery's application. Further, I want to highlight that it was the Western planning region where OHS found one of the largest number of untreated adults, and that's at page 163 of that plan. Okay, that's OHS, that's 2024 plan. But there's more evidence of need in this application. SISU cites repeatedly, and I'm going to give you Bates numbers, starting at page 13 of the CON application to the June 2021 Regional Priority Report for Southwest Connecticut. That's prepared by the Regional Behavioral Health Action Organization, otherwise known as the Hub, and you'll see that cited throughout. What we'd also like to submit, but is available to the agency as well, is that survey was recently updated to 2023. And the survey in 2021 named the priorities. Number 1, mental health. Number 2, suicide prevention. They don't change those priorities at all in the update. What I'll speak to in a minute, what they said in the one that was submitted with the CON application is anxiety, depression, serious mental illness were all specifically profiled. And 2 of the major risk factors for those who have those conditions is exactly what Ms. Clark spoke to when she was focusing on cognitive processing therapy. Traumatic events, and the other side of the facility licensing, we want to be an outpatient psychiatry facility, but we also want a substance abuse facility because they speak to co-occurring disorder throughout that report and the subsequent one. As to treatment, what they also speak about, page 131 of what they, I'll give you Bates numbers and Bates numbers to the CON, but page 131 of that report, supportive services. They name housing and case management. What did you hear today about holistic care? And how that helps in that. Another large concern, I'm at page 132 of the regional plan for Southwestern Connecticut, was the lack, and I'm quoting now, the lack of one-stop shop for behavioral health care needs, including the lack of comprehensive services from mental health and substance abuse combined and offered by one service provider. That is the entire concept between SISU and the other types of facilities that are available in this region. Page 133 says recovery focused on, among other things, job opportunities and the concept of, quoting again, 7-day window, the need for an emphasis on aftercare and check-in following an individual's discharge from a treatment recovery facility. I'm just going to equate that to what Mr. Silva spoke about as to the advantages of that KIPU system, tracking that handoff to either step down or inpatient services. So this is all in addition to the 2022 CHNAs for the 2 largest safety net providers in this service area, and where the targeted population is mainly in what they think will be their catchment area. City of Norwalk, City of Stamford. And I would only, I know OHS looks very closely at those when they're filed, but both mental health, major top priority item with both, and the 2019 CHNA for Norwalk Hospital, where Ms. Clark has the most connection to. Again, it's been a long-standing priority. It hasn't been met, and it's named there. The second, so that's standard number one, is whether the applicant has demonstrated a clear public need for the facility and services and an understanding of current capacity in the service area. That's standard number one at section 6.7. Standard number two is whether the applicant has satisfactorily demonstrated that the identified population to be served by this proposal has a need for the proposed service. That's sort of the flip side, right, of need. It's who are you targeting? Who do you want to receive these services? Well, on top of that data, SISU's identified to you the areas that they want to serve. Co-occurring disorders. The CON application at page 62 and 63 speaks to that demographic of 18 to 64. It's much broader. If we got more than 500,000 people in this state seeking care, yes, you know, it's very alarming to everybody, young adults, but it's the issues really go to the individuals who are cycling through those EDs, and that's a much wider demographic. So they have taken the time to study who they are going to provide their services for. Standard number three is whether the applicant has satisfactorily demonstrated how its proposal will improve quality access to and cost effectiveness of healthcare in the region, and the applicant committing to providing the highest quality treatment modalities as recommended by the federal and state agencies. This is a capital investment of $300,000 in a office building that is going to conduct group therapy. If that's not an idea of the commitment that this applicant is providing to the service area, I don't know what is. But when we want to talk about, you know, standards that are going to apply, best practices and so forth, we point you to what's already been submitted in the CON application as to these evidence-based practices. First is on the substance abuse side, the applicant provided the 2022 DMIS Triennial State Substance Abuse Plan. That's the state of Connecticut, which states plainly that Connecticut remains in the grips of an opioid epidemic, and combating these disorders is a top priority in the state. That's not even mentioning synthetic opioids, fentanyl, etc. So that's page 3 of the report. The same DMIS report speaks to evidence-based therapies that should be introduced for these populations, including cognitive behavioral therapy, which Ms. Clark spoke to, contingency management, the whole issue again of tracking and those ongoing assessments that she spoke to, and motivational interviewing that the applicant will do. Well, that's what Mr. Silva just finished speaking to. And that's the idea of what's your purpose? What's your job? Are you taking care of yourself now? So they are following best practices. Applicant also provided the DMIS guidelines going back to 2008 for providing these services. And those are repeatedly cited in the application, starting at Bates number, page 14. As to the DMIS report of 2022, you can look to Bates numbers 40 and 77 of the CON application with respect to that. They also, at Bates number 36, provided the ASAM guidance, American Society of Addiction Medicine, their national practice guidelines. So these are state-of-the-art current therapies that have proven to work on a patient population where I've seen literature that you have a recidivism rate of up to 80%. So everybody you can save. There's something else, I believe, in the Southwest Regional Report that says, if you can prevent this, with every dollar spent, you've already saved the healthcare delivery system $10. So, you know, I think that speaks for itself. Standard number 4 is whether the applicants propose in 6.7 provision of healthcare services to relevant populations and payer mix promotes access to all Connecticut residents and its willingness to accept all types of health insurance. Mr. Silva didn't say it, but their current, and to speak to, this applicant is not providing PHP and IOP without a license to do so. That's no accreditation, that's no payer network. It's providing therapies under licensed providers, individual providers in this state. And it's a good thing it's doing it, because they told me it's 60% Medicaid. And if you look at table 9, they're starting off, as Mr. Silva said, at a 10%. And I leave it to OHS to think whether that's significant for a for-profit provider to commit to. And look at the ramp up to 18% in year 3. So this is not a provider that is going to leave the Medicaid population unserviced. Standard number 5 in 6.7, and I picked these standards because I think this is an applicant that meets these current standards, is whether SISU has satisfactorily demonstrated the proposed project shall not result in an unnecessary duplication of existing or approved healthcare services, either publicly or privately owned. Far from duplicating the state services, what Mr. Silva spoke to is being a resource for those state services. And in terms of duplicating other private facilities and the services they provide, I'm not going to repeat myself or what the witnesses said about what holistic care and case management and tracking can achieve. And that's the distinguishing factor here. And there's no one who stepped up, became an intervener to say, well, that's exactly what we do. They're silent on that. Standard number 6, and I do want to also point out what I think is extremely innovative. And it's a challenge for the best of providers, is at Bates numbers 64 through 71. And as somebody who's close to the healthcare delivery system, I'd love to see, is the willingness to participate in accountable care organizations. Of course, they can't. They don't have the primary care census to deliver that, but they can be an adjunct and they can help with respect to making care more value-based and more accountable in this state. Standard number 6 is how consideration of the CON application decisions made after the publication of the statewide plan. Well, that's not applicable as far as I know, hearing officer, because that was published in June. I'm unaware of any approval in this market for IOP, PHP since June of 2024. And certainly none of that offers the services that SISU is going to. In summing up, we would like to submit the late file, the Connecticut Hub report, which is targeted to this region, targeted to mental health and substance abuse, which I think is, very helpful. The data before you, I think there's another unsubstantiated claim in one of the intervener's letters is that apparently needs leveling off. Well, the data, no unsubstantiated. Data certainly doesn't. The facts don't speak to that. Look at your own figure 6.1 in the statewide plan. I think what you have before you today is a provider that wants to be innovative, is committed upon granting licensure to run PHP and IOP programs that with the Keep You system that they have can maybe help in one of OHS's recommendations in the statewide plan at page 19, where the agency says OHS wants to gather additional data on the use of behavioral health care services by type of care and condition, severity, to determine if capacity is meeting patient needs. I think it's important to say, is what's out there meeting patient needs? My client feels there is a way to meet patient needs better. That's the whole issue here. The rest of that recommendation is integrate this data with observed use of behavioral health care services in different settings to estimate remaining unmet need. Again, I think both the CRM, well, especially the CRM, can help the OHS do exactly that. For all those reasons, we do respectfully request that this CON application be approved. We will be timely with our late files, and I do want to thank the agency again for its time and attention.
All right. Thank you very much, Attorney Cowherd. I appreciate your closing statement. I would like to thank your applicants for also attending the hearing today. This hearing is now 11:56 a.m. I'm going to go ahead.
Hearing officer, before
sure.
you close the hearing,
Yeah.
I saw you visually. Can we submit as the final late file which is available in the agency, the hub?
Actually, as you were speaking about that, I looked and I thought that it would be actually appropriate to put it with late file D.
Okay.
So
Makes
you
sense.
can lump that into late file D, which is the existing facility capacity and evidence that is available to support the need for treatment. So fits right into D. If you would like to attach that to late file D, we can go ahead and do that.
Links or attach?
Attach a copy.
Okay.
There are many pages in this. I have personally gone through at least, I believe you filed at least 2,000 pages. So we've gone through at least 2,000. But let's put a few more pages. So let's attach a copy.
Understood.
Yes, but it does fit, I think, nicely into D. So please submit that as part of D. All right, so we will add that, and it's called the Hub, H-U-B as in boy?
Yes.
Okay.
That's it is one of the planning agencies, I believe, that DEMIS contracts with to determine need in the state, but that's easy, concise way of saying their name.
Perfect. Okay. So we will go ahead and add that into D. I will, like I stated earlier, send you a an order for the late files that will be due on October 23rd by the close of business. I would like to thank everybody for attending this hearing today. It is now 11:58 a.m. I'm going to go ahead and adjourn the hearing. However, the record will remain open until closed by OHS at a later date. Thank you for attending, everybody, and thank you to our stenographer. Have a nice day. Goodbye.
Thank
Thank
you.
you.
Have a good day.
Thank you.